it's an issue here, and is part of that to pursue my medical review officer training and certification. So I'm going to talk about sort of the challenges and pitfalls and best practices that we have come up with here. Would love for this to be interactive and to, through this, kind of hear about your experiences and challenges that y'all face over there. And so please interrupt me at any time to ask questions. Okay, so my goals for today are to first talk about the different types of urine drug testing modalities that exist. I find that there can be a lot of confusion in the nuances of this, so I'm going to spend a little bit of time talking about this. And then to focus for a while on fentanyl and its metabolites and how they behave in the body. And then to look at, understanding how fentanyl works in the body is one thing, but what does the literature tell us about how long fentanyl stays positive in people's urines for? And with that basis, I'm hoping to turn to kind of the common challenges that we face in interpreting fentanyl drug screen results and what we've learned through that. And then recently, in the last year or two, I've assembled a work group here, which has involved representatives of our child welfare, family treatment court, our toxicologists, our public health nurses, and our physicians to form a work group about best practices for urine drug screen interpretation. And we have just published the sort of best practice guidelines that work group came up with. And so at the end, I'll sort of review those, which is basically a summary of everything I'll talk about until then. Okay, so starting with the two types of urine drug tests, there are screening tests and there are confirmatory tests. Screening tests, and for some of you this might be a review, but I feel like it's an important thing to get the basis in. Screening tests are the kind of thing that you would pee in a cup and get 2 lines if it's positive, or 1 line if it's negative. We call them immunoassay based tests. They're cheap and easy to do, but are prone to false positives. So I'll talk about those first, and then I'll talk about confirmatory tests, which are not cheap, not easy, but much more accurate. So how immunoassay or screening tests work is that they depend on the interaction between an antibody or a protein that is designed to detect a certain molecule and that molecule. So let's say in this case, we're talking about fentanyl, and we create an antibody, a protein that is designed to detect fentanyl, and it has a signal on it. And when we put that antibody in urine that has the fentanyl in it, the antibody or the protein will bind that fentanyl, and in that binding, release a signal. And we'll see that signal and we'll say, hey, look, there's fentanyl in this sample. But this entire process relies on this protein that we created being able to accurately identify the fentanyl, which is where we run into issues. Because that antibody might recognize something that looks a lot like fentanyl, but is not fentanyl. So for example, early tests, here on the left bottom, it says the word loperamide. Loperamide is a medication for constipation. And at the top, you see the molecular structure of fentanyl. And it's like a hexagon. For those who took orgo, this will be familiar. For those who didn't, this is my abbreviated science lesson. Here's just a hexagon with a bloop, bloop, bloop. And here in the loperamide, you see a similar structure, the hexagon with a sort of S-like structure. And so early fentanyl immunoassays were detecting this constipation medicine and turning positive and saying this person has fentanyl in their system, when actually they just took a constipation medicine, because the protein that we had created to recognize fentanyl was recognizing something that looked like fentanyl but was not fentanyl. And I give this as the most obvious example, but it still happens very frequently that these antibodies that we create are recognizing something that is close to what we're looking for, but not exactly it. So what do? We screen with these tests. These tests are cheap and easy. So we screen with them. And then when we have positives, we need to make sure that those positives are real. And we do like a second check with a confirmatory test, which is most commonly LCMS. So this is a second science lesson. Like, what is LCMS? What is this confirmatory test? This is if you're using a lab that reads out to you not only positive, negative, but also quantities of the drug. It's most likely using LCMS. Here in San Francisco, our child welfare, when they test people, they are testing using a lab that uses this method. And so the welfare workers, the protective service workers will get copies of lab results that will have not only what is positive, but also how much of it is present. So this is how this works. It has 2 steps. The first step is liquid chromatography. The second step is called mass spectrometry. Basically, in the first step, you take the urine, and it separates all the molecules in the urine by running them through a column. And then it takes all those separated molecules in the second step and adds a charge to them. And then it like looks at their mass to charge ratio. And each molecule has a specific fingerprint. And then it looks at that fingerprint compared to this library of all the other fingerprints and matches them up. And that's how it's able to specifically identify molecules accurately, where we don't really worry about false positives. So that is all honestly so boring, and I've learned it like so many times and still find it kind of boring. But the TLDR is screening tests are wonderful for their availability, but because they're prone to false positives, should always be followed up with a confirmatory test before any high stakes decisions are made. Because the confirmatory test can accurately identify the substance we're looking for, but it's not cheap and it's not fast, so it's not a great idea to use it on everybody. Okay, that's my background on the two most common types of urine drug testing modalities. I'm going to move on next to fentanyl and how it sort of works in the body. Does anybody have any questions before I move on? Okay, well, then I will move on to pharmacokinetics of fentanyl. So pharmacokinetics, generally, when we think about a drug in a body, we think about it in 4 different domains. And just backing up, the reason I'm talking about this is, as like my overarching picture, is that urine drug testing in the era of fentanyl is way more complicated than it was before we had fentanyl in our system, because fentanyl is more complicated in the way that it interacts with the body and the way it interacts with urine tests and how long we can detect it for. And so like in the last few years, I don't know about you guys there, but over here we've had this like major reckoning with our ability to accurately rely on urine drug testing, because everything we thought we understood about it has completely changed in the era of fentanyl. And so we've had to really like unpack like, what do we understand about urine drug testing? What do we understand about fentanyl? And then put it back together to be like, okay, here's our more nuanced approach to understanding urine drug testing in the era of fentanyl. So I started by talking about the urine drug testing itself, and now I'm going to talk about the fentanyl. Hopefully we'll put it back together at the end. So fentanyl, when we think about drugs in general coming into the body, we think about how did they get into the body? What are their absorptions? Because it matters whether we smoked it, whether we injected it, whether we took something as a sublingual tablet. That will impact it in the body. And then we think about, where does it go? How much volume does it have to distribute over? So like giving a gram of a medication to a 10-pound baby or a 200-pound adult, going to be really different because of the area that it distributes into. The next thing we think about is, how is it broken down? What is its metabolism? And then finally, how does it leave? What is its excretion? And let's dive into each of these. So its metabolism, how is it broken down? I think the easiest kind of example where we think about the impact of this is methadone in pregnancy, or at least in my domain, methadone in pregnancy, because people who are on methadone before pregnancy, they need to have their methadone dose like basically doubled over the course of their pregnancy, because methadone is metabolized by enzymes in the liver, and those enzymes, the CYP enzymes here, are way, 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 way more active in pregnancy. And so people run through their methadone super, super quickly. And so they need much, much, much higher doses. But it's not just pregnancy that impacts these enzymes. Other medications impact these enzymes, foods do, genetics do. And so how you metabolize fentanyl is about a lot of things, including how do these enzymes in your liver, what is their like innate activity? Another thing that matters about how your body metabolizes fentanyl is its excretion. How you excrete a drug will depend on, first, like your BMI, because fentanyl stores in the fat. And so more fat tissue, more storage, longer excretion period. It's also impacted by how well your kidneys work. If you are going to excrete this substance in your urine and your kidneys are barely making urine, it's going to hang around a lot longer. It's also impacted by how you administered it, how well your heart works, how much protein you have in your body. So lots of factors impact not only how fentanyl is metabolized, but also how it's stored and excreted. And so I say all of this to say that until a couple of years ago, the beliefs that we had about fentanyl were that it had a short half-life, meaning you use it and it quickly redistributes in your tissues. Maximum brain concentration is reached in 90 seconds, and then it quickly decreases and it's out of your urine by 3 days. But all of those beliefs, those are all based on studies that were done on a single pharmacologically administered, so administered in a hospital, dose of fentanyl. and they don't reflect what happens with your absorption, excretion, metabolism, and distribution when we're talking about chronic fentanyl use. Um, Another kind of factor that plays into this is that when we think about something that has a quick half-life, we think, looking at the green bar first, you take it, it peaks, and it runs out. You take it, it peaks, and it runs out. But that's not considering what happens if you take it repeatedly before it's had time to get excreted. Then what you have is the levels that build and build and build and build, and that slows down how long it will take to eliminate it because you've built it up. And then the final sort of biology lesson that I'll say that impacts these fentanyl urine drug screens before I go into some examples is assay precision. So this is a graph. On the x-axis is drug concentration, and the y-axis is the precision of the test. And basically what this shows us is that as the level of drug in the specimen decreases, the precision of the test decreases. So over here, the drug concentration is low. The precision is also low. This is the total imprecision. So like 20% imprecision on this low concentration, whereas at a high concentration, it's less than 10% imprecision. So what does that like mean in human terms? Is that if you have a really dilute sample and you test that sample 5 times, it might turn positive once, even if it's the same sample. But if you had a more concentrated sample, it would turn positive all 5 times that you tested it because the assay is just not precise at really dilute concentrations. Okay, with all these facts in your mind, I'm going to take us through a history lesson and then some cases. So when did we even start testing for fentanyl in urine? We started testing for fentanyl in urine in the 1980s. That is when we had our first studies that showed us that it takes 3 days for fentanyl to get eliminated from the urine. And as I said, those studies were all based on, one medicinally administered dose of fentanyl. Then in the early 1990s, we learned like, hey, it's not just fentanyl. If you take fentanyl, it will break down to, it's a breakdown product, norfentanyl, and that will also stick around for like 3-4 days. Okay, again, we're still talking about hospital administered fentanyl. Then in the late 1990s, the fentanyl patch came around. And that was the first time that we saw like chronic fentanyl exposure as a concept because, the patches are on for long periods of time. What we learned from that was that when you are chronically exposed to fentanyl, it does deposit in your fat and your skin. And so it does take a little bit longer to eliminate, but still, fentanyl patches are tiny, tiny doses of fentanyl. And so like we learned that concept of deposition and sort of prolonged elimination, but it still wasn't lasting very long. Okay, so those are the 80s and the 90s. And then in the 2010s, fentanyl comes on the drug use scene. But we're still basing our understanding of it on what we learned 2 decades, 3 decades prior, that it lasts for 1 to 3 days. And then come the 2020s, where we start having our first data that tell us that actually maybe it lasts longer than 1 to 3 days. The first real study to show this was a study of 12 participants in like a 1-month residential treatment program, and they were enrolled at the beginning when they got to program, they were positive for fentanyl. And then they were just like tested to see how long they would test positive for fentanyl and norfentanyl. And what we see in this graph here, the black is fentanyl and the white is norfentanyl. We see that the fentanyl stays positive for like almost 20 days, and the norfentanyl stays positive for just a little bit longer than that. So we're like, oh, okay, it's lasting longer than 3 days. Interesting. Okay. Also in 2020, we get a case report of a pregnant person who continues to test positive for norfentanyl for about 70 days is her last positive test. And this is the first time we see it lasting for this long. So this person's like kind of understandably, her welfare workers were like, why are you testing positive for like 60 days longer than we've ever seen anybody test positive before? You're still using, and reunification was delayed for a long time. What is important to know here is like at this lab, fentanyl is only detected to a level of 38 nanograms per milliliter, but norfentanyl is detected to 0.5, which is why she tested negative for fentanyl quite quickly because it's not very like sensitive for fentanyl, but tested positive for norfentanyl for a really long time because we're able to detect much, much lower levels of norfentanyl. You can see we're detecting levels of like 2 here. And now, in retrospect, with a couple more years of understanding, we understand like, no, these are declining norfentanyl levels over time. That is just sort of what we expect because fentanyl and norfentanyl stick around much longer. Okay. Then we got some more data. I think this study in 2024 is super helpful for understanding what it looks like. So this is a case series of 3 individuals from a postpartum addiction medicine program, similar to the one that I work in, looking at their norfentanyl levels after they stop using drugs. And I want to talk about case 1, which is in yellow. So in case 1, we are seeing this yellow line that goes like spikes up and down, up and down, up and down. But you see around the 2.5 line, a dark black line that's going horizontally. So that is the cutoff level at which this lab can detect norfentanyl. And what you're seeing, if you were this person's worker, what you would see at 150 days, they test negative. Then they test positive, 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 negative, 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 positive, negative, negative, positive, positive, negative. And so one way you could look at this is saying like, hey, they keep testing negative, but then they test positive again. So that must mean that they're using again because they got to testing negative and then they tested positive again. But if you zoom out, what you can see is like, no, actually, they are just constantly testing right at the limit of detection, right above, right below, right above, right below. That is more likely a problem of assay precision because at these low levels that are basically at the level where the test can possibly detect into, it's not always going to be accurate. So there'll be days where it tests positive and days where it tests negative, but it's not because they're using again. If they were using again, we would expect a much, much higher spike than 2 nanograms per milliliters. It's just because we don't have the ability to be precise at these levels that are so close to the cutoff. And then we can see that this person was testing positive until like 250 days. And so I think the lessons to take from this case are not only that actually you could test positive for way longer than 3 days, you can test positive for like most of a year, but also that you might turn negative and then turn positive again. And what matters in that spectrum is the levels that we're talking about and sort of the curve that that looks like, rather than just like positive and negative as a binary. Questions about this before I go on? Okay, I'm going to bring you 2 cases then from our local setting, which working on publishing, not yet published, but just to illustrate that this is not like a thing that never happens. It's just a thing that we're not like capturing enough. So I'm going to tell you about 2 of my patients who are also, so this first patient is a dad. I work with him and his wife and his kid. Mom and dad were both using during pregnancy and then had the baby, really committed to recovery, got into recovery. Mom went to residential treatment with the baby. Dad went to separate residential treatment. And they both like did well. Mom started testing negative pretty soon, reunified, moved into family maintenance and case closed pretty quickly. Dad had a much longer course and that was largely because of his urine testing. So something that I need to explain about all testing is that it really matters the cutoff levels for fentanyl versus norfentanyl. Remember that case report we looked at where fentanyl was like only cut off at 38, but norfentanyl was detected to really little levels? So in San Francisco, we have unfortunately the exact opposite situation where we detect norfentanyl until 5, but fentanyl until 0.5. So that means you expect norfentanyl to stick around longer than fentanyl usually. But in our setting, because we stopped detecting norfentanyl at higher levels, it ends up being fentanyl that sticks around, which is really confusing for everybody and a terrible plan, but that's besides the point. So this patient, I want to look at their fentanyl levels. So if I showed you the graph of what his fentanyl levels looked like before when he was using, they were much higher. But now let's like focus on when he like stops using. And you can see that his fentanyl levels, they range between like 7 and 1 and negative for basically 197 days. So if you were this person's worker, what you would see is positive, 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 negative, negative, positive, negative, positive, negative, 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 positive, negative, negative, right? Again, like so confusing. Everything clinically, like he looks great. He is engaged. He's such a good dad. But we just like, why does he keep testing positive for fentanyl? Like, is he continuing to use fentanyl? Um, the answer that I would say is no, these levels are really low. People always ask, like, what level would you say is the cutoff for like this indicates use? Nobody's published about this, nobody knows about this. But when I have talked to the director of our toxicology lab here, she has basically been like, 10, below 10 is like not new use. Like people who are using, they're in their triple digits at least. So below 10, like a level that remains like consistently low positive, below 10, you can basically assume is not new use. And so this person, really, they stayed below 5 for the most part this entire time, but it was just like often when it would get presented in cases, it would be like, well, he was negative for 3 tests in a row and now he just turned positive. But you can also understand that if that was in March, he turned positive at a level of like 1 nanogram per milliliter. And so our counter argument was like, he didn't use again. This is just an issue of assay precision. But you have to like also graph it out to really see that. You can't just look at it one test isolated. Okay, so that's him. He's doing great now. One day the test turned negative and never turned positive again. And everything, all the noise hushed down. And now they've been reunited for years and are doing great. A similar case of a patient. So similarly, because our norfentanyl stops testing at 5, she tested negative for norfentanyl pretty quickly, but her fentanyl levels went between 0 and 2 for 245 days. The scale on this is a little bit different. So all these, like the highest spikes here are just below 2. And so she was going positive, negative, positive, 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 negative, positive, negative, negative, right? So confusing. It looks like she's using if you're just saying, well, she's been positive 5 times in a row. But if you zoom out and are like, wait, she's like been positive at a level of 1 nanogram per milliliter forever, and she's never had a spike to suggest she used again. It's just sort of been this low level positive. This is more likely like it's stored in her fat, it's slowly coming out, the assay isn't precise, like all these factors that combine to make this just like really hard to understand. And again, that you can't really understand unless you plot it out and like are understanding the numbers relative to each other. Similarly for her, like she was clinically stable in her recovery. She was super engaged. She had a lot of people on her team sort of advocating for her, and eventually she was able to reunify and one day turned like 300 days later turned negative finally, and the case closed. Okay, so kind of summarizing the common challenges that we have. Firstly, our beliefs that fentanyl only sticks around for 1 to 3 days are based on old, outdated studies that are from 2 decades before fentanyl was a drug of abuse in our like street system. Two, in reality, it can sometimes stick around for much longer, on the order of months, and that is impacted by how much you use, for how long, how often, how much adipose tissue you have, like what your BMI is, how well your liver and your kidneys function. And then 3, the level of the drug in the specimen decreases, the ability of the assay to detect it accurately decreases as well. And then things I didn't add here, but 4, the levels of cutoff at your labs themselves make a difference. And like we basically a few months ago asked our lab to move their cutoff from norfentanyl from 0.5 to 1. And like just so many issues dissolved because like those lab tests that were positive at 0.75, like they were never clinically relevant. There are plenty of labs in the city that never detected to that level, but the lab that CPS was using was detecting to a lower level. And when we just moved it up a touch, we like got rid of so many problems. So just being aware if your client switches labs, what the new cutoffs are and how those relate. We definitely have a lot of people who will switch labs mid-testing and now all of a sudden be testing positive. And you have to remember, like, hey, is this really a new positive, or are the 2 labs using different cutoffs and it's just something that wasn't being captured before? Okay, so this is our best practices. This is available online from the San Francisco Department of Public Health. They're guidelines for interpreting drug test results in non-medical settings. And then they were made really for like the world of child welfare and family treatment court in San Francisco. And so we've really talked through a lot of these things, but I will just sort of review these guidelines, and the link is at the bottom here of the screen. Oh, get it back. So the key message is, because fentanyl urine drug testing can be so complex sometimes, not always, a lot of times it's quite simple, but sometimes it's complicated. In those cases, a medical professional should really be consulted to help with accurate interpretation. Like if somebody looks like they're using drugs and it says that they're using drugs and all clinical signs point to they're using drugs, I don't think that requires consultation. But sometimes the things are just not lining up. And in those cases, it can be helpful to have a medical consultation about what is going on, either with an addiction medicine doctor, a toxicologist, medical review officer. Two, screening tests, immunoassay tests should always be followed up by a confirmatory test if positive. And so, last week I had a patient who had a presumptive positive screening test. Her kid was removed. She came same day, got confirmatory testing. It was actually negative. It was just a false positive, and her kid was reunified. And we really tried to avoid that kind of chaos for families. And so to wait to make high stakes decisions on confirmatory tests, which might be different where y'all live, but for us, it only takes, like, we can get a confirmatory test same day or the next day. And so waiting for those before making high stakes decisions. And then we talked about the different types of tests, the screening test and the confirmatory test. We talked about how screening tests can have inaccurate results. One thing I didn't talk about, which I should mention, is the other like really common area where we see false positives is when we're talking about stimulants. A lot of the medications for ADHD are stimulants, and they will cause a positive on an immunoassay test. And so anybody who is on medications for ADHD, like you need confirmatory testing to understand what is turning positive. The next two pages. We talked about how urine fentanyl can remain positive for a long time, up to 250 days, how lab cutoffs can impact test results. Something I haven't talked about yet. Here, at least, lawyers love to order hair testing, and I cannot more strongly discourage the use of hair testing. Hair testing cannot tell you when a person used drugs, how much they use, how often they use. And so it's going to give you information that is unusable. And now you're going to feel like you have to explain this hair test, which, first of all, might reflect drug use from a long time ago. Second of all, hair of all the bodily fluids or substances is the most amenable to like environmental exposure. And also different types of hair hold onto drug very differently. So dark, coarse hair retains drugs at a significantly higher level, like we're talking orders of magnitude, than light, fine hair. And there is a lot of bias in that. So if you want to use something other than urine, may I advocate for saliva, which gives you like much more in the moment results, more like recently relevant results, and not hair. Okay, that's all I have to say on my very quick run through. I'd love to hear what challenges y'all are facing or what questions folks have.
This was great. Thank you. I had a question. When you were diagramming the individual cases of the positive negatives, over months, was that on the screening test or was that on confirmation?
Confirmation.
Okay. So
Yeah.
even the confirmation is faulty.
Yeah, that's how we have the levels, is because it was on confirmation.
Okay.